everyone. Thank you for joining us for our annual Fall Amah Mutsun Speaker Series event. My name is Kamiko Hostler, and I would like to introduce Chairman Lopez, who will be opening up our event today.
Thank you, Kamika. And I'd like to welcome everyone to today's Mutsun Speaker Series event. When I say thank you, I want to give a special thank you to the American Indian Resource Center. We have developed a special relationship with our tribe and our council members with the American Indian Resource Center. And over the years, this is the 24th consecutive Amah Mutsun Speaker Series. We have a spring speaker series and a fall speaker series. This event started in November of 2009 as part of the indigenous programs with the director of the Resource Center at that time, Professor Dennis Tibbetts. And we were invited to come on in and talk to the students in the Resource Center and to see how our tribe, who have ties to Santa Cruz, we have our ancestors who were taken to Mission Santa Cruz, although we are not Santa Cruz Indians by lineage. Our relationship with the university has been tremendous, and it was a resource center that started it all. Our very first speaker series was with Dr. Marie Yellow Horse Braveheart, who spoke on historic trauma. And over the years, we've presented on topics as diverse as the Indian Child Welfare Act, federal recognition, and a lot on the environment, and a lot of other topics. And it's just been tremendous. And we brought in speakers from across the country to speak at this event. We're thankful to the relationship we have with the university and the American Indian Resource Center. We have had, since that first relationship with Dr. Tibbetts in 2009, we've had two students who have come out of high school and transferred and applied and were accepted to UC Santa Cruz and graduated from Santa Cruz. And they're both in PhD programs now. Carolyn Rodriguez is at UCLA getting her doctorate degree. And Julissa Pineda Lopez is at University of Michigan, getting her PhD in psychology. And so it's made a huge difference in our life, the relationship we have here. We're continuing that today with a speaker that we truly look forward to. The speaker is Professor Keliiaa, excuse me, for that pronunciation if it's wrong, and I'm sure probably is my ear. And the professor will be speaking on settler colonialism is a sickness, how federal Indian health failed Native women. The talk focuses on the question of Indian health among Native domestic workers in the 20th century in the San Francisco Bay Area. This is an important topic to all indigenous people. Federal Indian health has failed in so many ways. We are a federally unrecognized tribe, so we were not even allowed to get services under federal Indian health until recently, and we're only allowed to have outpatient service through Indian health. But when you look at the statistics of Native peoples, when you look at depression, when you look at so many illnesses and disease, et cetera, and blindness and diabetes, et cetera. You know, it's a Native American that are always at the top of the percentage ladder there, that suffering the most. And this is an important topic to understand and to know that we must make changes. So with that, I'd like to welcome you to today's speaker series. And we ask that you listen with your hearts so that you can truly understand what we will all learn today. Thank you.
Thank you, Chairman Lopez, for your words. We're honored to have you with us today. Hello, everyone, and welcome. My name is Keliiaa Hostler, and I'm an intern for the American Indian Resource Center. I use she, her, hers pronouns, and I'm a member of the Hoopa Valley tribe. As a California native myself, I'm very happy to be here with the Amah Mutsun Tribal Band today and presenting our incredible speaker. The AIRC is dedicated to supporting the needs of American Indian students at UCSC. It is one of 6 resource centers on campus. The AIRC is also home to the People of Color Sustainability Collective. Throughout the year, we host workshops and presentations that raise awareness about issues that pertain to Indigenous people. We have been hosting the Amah Mutsun Speaker Series for many years, and this is the 3rd time we are holding it virtually. So we ask for your patience as we move through the event today, and thank you all for being with us. I'm very excited to introduce our speaker, who is part of our very own UCSC family, Dr. Keliiaa. Keliiaa is Assistant Professor of Feminist Studies here at UC Santa Cruz. She is an Indigenous feminist historian, and her scholarship engages Indian labor, exploitation, dispossession, and surveillance of Native bodies, especially in Native Californian contexts. Her book project, Unsettling Domesticity, centers Native women's voices uncovered from federal archives. She is Yerington, Paiute, and Washoe, and her tribal communities inform her scholarship. Today, Dr. Keliiaa will be discussing how federal Indian health has failed Native women. If you have any questions during the event, please type them in the Q&A box at the bottom of your screen, and we will share them during our Q&A session. I will now turn it over to Dr. Keliiaa.
Thank you so much for that wonderful introduction. And let me share my screen so we can get started. All right, if I can get a thumbs up from anybody, if everybody can see this. Okay, great. All right, well, good afternoon. I am very delighted to present my work today for the Amah Mutsun Speaker Series. Thank you so much for having me. My talk today is entitled Settler Colonialism is a Sickness, How Federal Indian Health Failed Native Women. My research explores the intersections of race and gender and their historical consequences. Specifically, I study a Northern California-based iteration of a national Indian labor system known as outing. Today, I'll discuss a new chapter of my book manuscript to reveal fickle benevolence, federal negligence, and the dangerous inadequacies of Indian health services that ultimately cost Native women's lives. Given the difficult content of my talk today, please take care of yourselves. I just want to give a brief roadmap of my discussion today. I'm first going to talk about a couple of brief definitions, give a guiding sort of question and sort of tell you what this topic is about today. I will comment on our current moment in a global pandemic. And then I'll delve into a brief history of Indian health and tuberculosis, which is the main topic of today's discussion. And then finally, I'll delve into 3 main cases of Native women's experiences. So at the end of the 19th century, reformers looked to a mandatory Indian education system to solve the Indian problem. And I have here a map of several boarding schools. This is actually not extensive. There's way more day schools and mission-based schools as well, but just to give you an example of that. The federal government created Indian boarding schools to separate Indian children from their families and to mold them into Christianized, patriarchal, thrifty laborers. These institutions, 367 in total, were gendered in nature and operated on the labor of Indian children. Indian boys would build the dormitories, Indian girls would clean them. And where boarding schools separated Indian children from their families during the school year, outing programs that stem from these schools kept children during the summer and winter breaks. Roughly each boarding school operated its own outing program, and through it contracted out student labor to local white farms and homes. Where Indian boys might labor as farm hands, masons, or blacksmiths, Indian girls solely labored as domestics. Both on and off school labor was peddled as work experience for the purpose of education. Outing was the cornerstone of 19th and 20th century Indian policy. So on this map here, I have a star which indicates where the Bay Area outing program was. And it worked a little differently than most boarding schools because it actually funneled Native women from boarding schools. So it's actually bringing them from these Western-based schools. From 1918 to roughly 1942, the Bay Area outing program coercively recruited over 1,000 Native women from US Indian boarding schools to work as live-in housemaids in affluent homes across Berkeley, Oakland, and the greater Bay Area. In exchange for room, board, and menial pay, young Native women, some as young as 14, cooked, cleaned, and served as caretakers in the private homes of their employers. For roughly 2 decades, the Bay Area outing program was part of the federal government's civilizing mission, establishing a readily available exploitative labor market. This prolific outing program was exclusively for girls and women and amassed over 1,000 outing participants. Broadly, the Bay Area outing program was intertribal, with most women from California, the Pacific Northwest, and the Southwest. Once in the Bay Area, outing matrons who ran the program placed girls in homes throughout the region. Positions were concentrated in the East Bay, especially in the affluent city of Piedmont. Some girls outed for short stints during seasonal breaks, while others worked for the same family for years. While some women outed in their early 20s and 30s, most were adolescents, roughly 14 to 19 years old. Regardless of age, girls and young women often came from institutions that were rife with government-created health issues, for instance, overcrowded boarding schools, and under-resourced communities and reservations. These conditions followed them to the Bay Area. My talk today addresses the overarching question: how did the Bay Area outing program affect Native women's bodies and health? While some Native women may have appreciated the outing program, I closely analyzed 3 cases of outing women who became critically ill with active tuberculosis while in the Bay Area. To this end, I demonstrate the difficulties they experienced in accessing healthcare and uncover state violence shrouded as federal neglect. As I begin this talk, it's important to acknowledge the circumstances that have brought us online. We are still very much in a pandemic. It has been nearly 2 years since COVID-19 arrived in the United States, and it offers a very relevant framework for discussing tuberculosis in the early 20th century. In fact, to this day, TB remains a pandemic. It is a global disease found in every country in the world. And indeed, the COVID-19 pandemic has diverted tuberculosis resources, and the World Health Organization reports that TB is on the rise. And while COVID takes priority across the globe, the pandemic has shed light on vast inequality in public health, especially as certain racialized communities are more at risk of contracting the virus and dying from it. Conditions where people live and work affect a range of health risks and outcomes. Factors such as poverty and healthcare access have a significant influence on one's health and quality of life. According to the CDC, as of September 2021, American Indian and Alaska Native people have 1.7 times more cases than their white counterparts, 3.5 times more hospitalizations, and 2.4 more deaths than white Americans. As I will discuss later, Native people suffered from tuberculosis at similarly high rates, if not extremely higher. The silver lining in these grim statistics is that a very high vaccination rate among Native American people is shared. 58.5% of Native people have received at least 1 dose of the vaccine, and 50% are fully vaccinated. Perhaps disproportionate infection rates inspired urgency towards vaccination, but many credit Native-run health centers with a successful vaccine rollout. Indian Health Services, IHS, a federal-run program for American Indians and Alaskan Natives, along with IHS affiliates, initiated on-the-ground vaccination education and campaigns that developed trust within the community. Indeed, the White House commended Oakland's own Native American Health Center for their successful vaccine and testing programs. As vaccination rates among adults and now children continue to increase, we begin to see some light at the end of the tunnel. And while this is very much the state of our contemporary moment, the tuberculosis pandemic in the early 20th century United States was a hard-fought, drawn-out illness that spanned for decades. Native-driven health facilities did not exist, and viable treatments and vaccinations took decades to develop. Before I briefly review the history of Indian health and TB, I'd like to provide a quick definition. So one of the things I'm going to be talking about today are U.S. Indian Service facilities versus public or paid facilities. So the U.S. Indian Service at this time, it wasn't called IHS or Indian Health Services. It was more the Indian Medical Division. And there were various hospitals and something called sanatorium. A sanatorium was really a medical facility for long-term illness, and it was typically associated with TB. It wasn't always just for TB. This is interchangeable with sanitarium, and sanatoria is the plural of this term. On the left here, I have Stewart Indian Schools Hospital in Carson City, Nevada. And on the right, I have Waymar Sanatorium, which is in Colfax. That was a paid facility. And these two facilities will come up in the talk. So throughout the 19th and early 20th centuries, widespread disease afflicted Indian country. However, Indian medical service was underqualified, understaffed, under-resourced, overworked, and underpaid. Therefore, care and delivery of services was inadequate. On reservations, policies like allotment prescribed poorly constructed housing that led to further spread of disease. Likewise, in Indian boarding schools, they were neither healthy nor safe. There, many children succumbed to disease or left with weakened immune systems. Tuberculosis was especially rampant. TB, also known as consumption, is easily spread like COVID-19 through a cough or sneeze. Symptoms include chest pain, coughing up blood, weakness, weight loss, loss of appetite, and fever. Those with dormant tuberculosis have no symptoms, but a weakened immune system can cause the bacteria to become active. Therefore, some become sick immediately, while others may become sick years later. Age can activate a dormant case of TB. Housing, workplace conditions, and length of workday are also factors. The most common form of active TB is lung disease, but the bacteria can invade other organs, spread to lymph nodes, bones, or the bloodstream. When in the lungs, TB causes the chest to fill with blood. Many TB patients will also experience a pulmonary hemorrhage, at least once and often repeatedly. Once a hemorrhage has occurred, there is not much that can be done. In its worst form, patients cannot breathe and succumb to respiratory failure. It is incredibly painful, and in the early 20th century, TB was the main cause of Indian deaths. So I have a slide here that kind of gives you a few brief statistics about tuberculosis. In the early 1900s, TB was the cause of 40% of all Indian deaths and ranged essentially from 30 to 40% respectively. And in some cases, those percentages could be higher. So for instance, in that same year, Nevada, among Pyramid Lake Paiutes, TB incidence rate was over 33%. And even though we have these statistics from the early 20th century, it's very likely there was undercounting as well. The Merriam Report, a lot of folks look to this as a document that really kind of was an indictment of the Indian Service, found that Native American people suffered 7 times as many tuberculosis-caused deaths per 1,000. And in some cases, this was extremely high. So for instance, in the Southwest, in Arizona, there was a tuberculosis death rate of 15.1% higher than the national rate. And by 1935, 17% of Native people were treated for TB in a hospital, sanitaria, or school infirmary. In 1928, the Merriam Report estimated that 1 in 10 people suffered from either active or dormant tuberculosis. Those afflicted with the highly contagious disease were sent to federal Indian sanatoria, school-based or otherwise. The Merriam Report determined that existing Indian Service medical facilities were below a minimum standard of efficiency, plant, equipment, and personnel. It was not only difficult to transport patients to these institutions, but reservation-based physicians and nurses were wholly inadequate for the job. Further, in either reservation or boarding school-based hospitals or sanitaria, little was done to detect the disease in its infancy. Diagnostic facilities, X-ray, laboratory, and tuberculin tests were not available in the Indian Service. Indeed, not until after World War II did the Indian Medical Division secure 3 X-ray machines that could detect the disease. Only on rare occasions were such tools sought from the outside, for instance, with patients who had access to other forms of healthcare. Nonetheless, in most cases, the diagnosis was not made until the case was well advanced. Ultimately, the Indian Medical Division was unable to detect TB until it was too late. As tuberculosis ravaged Indian country, 3 main factors and theories claim to explain the epidemic. The first was that Indian people were simply more susceptible to disease than their non-native counterparts. The second theory was that Indians were so overcome by the disease because they'd never been exposed to it. And the third prevailing theory was that full-blooded Indians were more susceptible to tuberculosis than those of mixed heritage. All theories pathologized Indian people and blamed them for the epidemic. Critically, these theories reinforced the eugenic notion that the epidemic was inevitable and nothing could be done to fix it, and that federal officials and the structures thereof were not responsible. It was not until the period between the 1930s and the 50s that new research discredited such theories. There was no connection between race and tuberculosis. The disease that ravaged Indian country well into the mid-20th century was caused by extreme poverty. Indeed, Native communities that suffered land theft, resource extraction, and dispossession would be defined as impoverished. Yet crucially, settler colonialism shaped these circumstances that put Native women and Native people at higher risk of tuberculosis, infection, and death. This risk affected every single Native home. These circumstances substantiate the conditions outing women experienced in the early 20th century Bay Area. Born in under-resourced communities or reservations and raised in Indian boarding schools, they were surrounded by death and disease. While they may have survived such deplorable government-made conditions, they suffered from compromised immune systems, and in worst cases with underlying diseases that remained undetected by the failures of Indian Health Service. The fact remains that once in the Bay Area, these women would have been able to tap into and benefit from both local and federal hospitals, but that was not the case. Ivy Sam, a 21-year-old Washoe and Paiute woman, applied to the outing program in October of 1930. She attended public school in Colville, California. Sam worked in 2 Oakland homes from November 1930 to January 1931. Upon arriving to the Bay Area, Sam was 4 months pregnant and likely intent on securing wages before giving birth. On January 31st, 1931, at 7 months pregnant, she entered the Salvation Army home in Oakland. This home was strictly for single mothers, and many outing women delivered their children there. However, complications required her immediate transfer to Highland Hospital in Oakland. On February 2nd, Matron Royce wrote to Superintendent Parrott of the Walker River Agency requesting assistance with Sam and another outing girl, Minnie Doc. Sam was hemorrhaging from her lungs, a common sign of TB, though this was apparently undiagnosed. Doc had TB in her bones. Both were gravely ill, hospitalized in Bay Area emergency rooms, and required immediate long-term care. Sam's situation was especially dire. Her few months of residency in the Bay Area did not qualify her for hospitalization. At the time, only county residents qualified for health care. Residents were defined as living continuously in the state for 3 years and at least 1 year of continuous residence in Alameda County. Given that many girls outed seasonally, most would have fallen in this precarious category and would have to seek non-emergent and long-term care at federal-run Indian hospitals and sanatoria. Fortunately, non-residents were given emergency aid. However, Sam was in a very bad state, and Matron Royce was hoping the 2 women could be sent to the Pyramid Lake Sanatorium. Days later, Royce directly petitioned a Dr. Snoddy at Pyramid Lake, pleading, "I earnestly beg you to give their cases favorable consideration." Royce gave Bay Area health providers the impression that both women could be immediately transferred to a government hospital, yet there were no beds secured, nor funds to transport either of them. Sam and Doc continued to be hospitalized under emergency care. On February 14th, Sam was transferred to Fairmount Hospital in Oakland, a facility reserved for the chronically ill and convalescing, including those with advanced TB. Her transfer suggests that Sam may have stabilized, but was still seriously ill. A week later, on February 21st, Sam was sent back to Highland Hospital. That day, she gave birth to a baby girl named Anna Mae. Days later, and weeks after Royce's first petition, Superintendent Parrott wrote to the matron that there was no room at Pyramid Lake Hospital for either woman. Parrott asked if he might be able to fund their continued hospitalization, and if so, Royce should send the rates. He further conceded that he had no means of transportation nor a suitable home for the woman. In response, Royce revealed that Sam's baby was premature by 1 month and in an incubator. Because Sam was both tubercular and syphilitic, the child would need a long and thorough treatment if it lives. She pressed, "Let me know at once what to do with them." Royce also divulged, "We, you, Dr. Snoddy, and myself are being severely criticized here by employers of Ivy and health authorities for allowing her to leave the sanatorium. I did not know that she was sick or that she had been at a sanatorium until the day before I took her to emergency. Apparently, before outing, Sam had been a patient at Pyramid Lake. Naturally, the medical team chastised Royce and her colleagues for a severely mismanaged case of not one, but two women and now an infant. In response, Parrott was indifferent. He conceded that Sam did not belong to the Walker River Reservation. Instead, her residence in the vicinity of Colville, California, meant that she was an unrestricted Indian. Though he claimed her family on the 1931 Indian census for the Walker River Agency, when it came to healthcare, he claimed the state was responsible. He explicated that if her status came to question, the Comptroller General might hold up payment for any care on her behalf, a risk he was not willing to take. In other words, he clarified the state of California was responsible for her care as any other indigent person needing care under the jurisdiction of the state. Parrott passed responsibility for the three patients to the state of California and Royce. He admitted, I can appreciate the criticism which is bound to rise in cases of this kind, and that if the matron had made an arrangement for the care of Doc, Sam, and her baby, he would do the best to help in financing it. He made no guarantees. While Parrott mulled the technicalities, two women and an infant remained gravely ill with no recourse. Sam had been hospitalized for a month. In March, Sam showed no signs of improvement, and Royce wrote to her relatives in Nixon, Nevada, you may come at once if you want to. Ivy Sam is in the hospital and is very sick. Though she had been hospitalized for a month and a half, it appears this letter is the first to inform the Sam's family of their daughter's grave condition. Meanwhile, Royce still attempted to locate an Indian agency responsible for Sam. She was aching to be rid of the case and wrote to the Sacramento Indian Agency declaring that Sam had caused us untold trouble and that if she belongs in your jurisdiction and you can take her, we will be so glad, for we have been placed in the most trying position because of her condition. Sam was deathly ill and Royce was feeling inconvenienced. Yet again, the matron was forwarded to the Walker River Indian Agency. And for a second time, Superintendent Parrott reflected on the technicalities of Sam's status. He offered no concrete support and surmised that with this class of Indians, it's difficult to know how to proceed. Sam was dying of neglect, and Parrott found the situation difficult. Weeks later, Sam's father, Pete Sam, wrote to Royce from Smith, Nevada. He finally got word of his daughter's illness and requested further information. She wrote to me and said she was sick. I wonder if you know anything about her. If you did, will you please let me know at once? Royce did not respond quickly. 2 weeks later, on April 29th, 3 months after she was first hospitalized, Sam, a single mother with a sickly infant, passed away in the Bay Area without her family by her side. Later that same day, Royce responded to her father, Pete. I regret to tell you that your daughter, Ivy Sam, passed away at 5 o'clock this morning. Ever since we knew Ivy was sick, we have tried to locate her folks, but were not able to do so until your letter, which I received only yesterday. Ivy either did not know where you were or did not want us to tell you. Royce claimed, we have repeatedly written to both Sacramento Indian Agency and Walker River Agency and endeavored to locate Ivy's people, though records do not substantiate this claim. Apparently, Royce sent a wire to Sam the day prior indicating his daughter's condition, but he would not be located. In her final words, Royce requested, we would like to know what you want regarding the care of the child. If we do not hear from you today, we will bury Ivy here. Given that Royce's letter took days to reach Pete Sam, a same-day reply was impossible. The Sam family would not be able to say goodbye, and a young woman would be buried without her family in a foreign place. According to records, Ivy Sam was buried May 1st. Some days later, Pete Sam wired a telegraph from Wellington, Nevada to Royce requesting they send his daughter's body back home. Yet again, Royce provided empty regrets. She responded, we received your wire too late to send Ivy's body to Nevada. We waited for 3 days and thought we were not going to hear from you. In response, Royce failed to mention that his daughter had already been buried days ago. She continued, you'll be glad to know that Ivy had good care during her sickness and all possible to do was done for her. I do not think she suffered at any time. The baby is having the best of care. Will you please let us know what to do with the baby and Ivy's clothing and cash? Pete Sam transferred work locations and responded from Topaz, California on May 16th. Rather than being justifiably cross with the matron, he extended his gratitude. I'll go out and see Mr. Steiner of the Stewart Institute and have him make arrangements to have Ivy's baby and clothing sent here. I thank you for the good care given to my girl before she died and is now being given to her baby. After Ivy Sam's death, Matron Royce and her colleagues and a local charity focus on the care of baby Amah. Sally Leverage of the Associated Charities of the City of Oakland asked Superintendent Parrott of the Walker River Agency if Amah could be sent home to live with her family. Parrott had a field matron assess the home in Colville, California, and the result was negative. Pete Sam had no wife, and his school-aged children would not be home to care for the infant. Moreover, there was no physician nearby for the baby's care and treatment. Parrott responded, "The family is very poor and have no means of support except a little work that Pete may attain by working as a laborer. The family and home conditions are very unsanitary. The oldest boy has tuberculosis and is in very poor health." Parrott described conditions of illness and economic hardship that were largely crafted and made worse by the Indian service, yet the context was completely lost on him. He concluded, "Under such conditions, it would be almost criminal to place the baby in such an environment." With Parrott's conclusion, Amah remained in Oakland. Another Indian baby was separated from its family under the guise of being unfit. In July, Bernice Sam, Ivy's sister, wrote Matron Royce inquiring about her niece and wondering if she could be sent to Stewart. Meanwhile, Parrott continued to discredit the family, stating to Royce, "Relating to this child's people at Colville, I cannot see how they would care for it at all." Instead, he felt the best arrangement would be the government and some home institution to care for the child. A week later, the question of who would care for the baby was irrelevant. Ivy Sam's baby, Amah, passed away on July 16th, 1931 at Highland Hospital. On July 20th, Royce conveyed the news to Parrott, stating, "She had the best care obtainable and everything possible was done for her. She never could have been well, so it seems best for her to escape further suffering." Arrangements had been made to transfer the baby's bills to Parrott's office. He was apparently fine with footing the bill for the baby's care, but did not do the same for the mother. It's unclear where the baby was buried or if any kind of services were held, but one thing was certain, Royce had once again failed to notify the Sam family. In August, Bernice Sam wrote Royce about her niece for a second time. "You told Pete Sam, my father, that Ivy had a baby girl down there. I'm going to tell you to send that baby down to Stewart, Nevada. You let me know first and let me now know how old that baby is. Answer right away, so please send her down." Months after Amah's complicated birth, the family was left unaware of the basic details of the infant's brief life. Royce finally responded to Sam weeks later, offering no condolences. She wrote, "When the baby was able to be taken from the hospital, it was placed in a private home and had the very best care possible right up to the time of its death. It was a little girl and its name was Amah." After one final letter regarding a medical bill, Ivy Sam's file ended. Ivy Sam's short few months in the Bay Area outing program took a horrific turn. Her pre-existing conditions of syphilis, tuberculosis, and pregnancy made for a complex health situation that was worsened by federal inaction and severe neglect. Upon entering the Bay Area, Sam was strong enough to work for 2 months as a domestic and apparently showed no signs of illness, but clearly something was seriously wrong. For months on end, she did not receive the long-term treatment she needed, nor was she able to see her family. For months, officials went back and forth over who had jurisdiction. Her status as a restricted Indian ultimately gridlocked the case. Royce and Parrott handled the case so poorly, their contemporaries criticized them. Sure, Sam had access to emergent care in the Bay Area, but was passed around from facility to facility until her untimely death. It is impossible to know if things would have worked out differently had Royce, Parrott, or any federal official sent Sam to a specialist or a long-term hospital or sanatorium. We will never know if administration could have made a difference, because in this case, they did not. No hospital bed was secured, no plan of action was made. When Sam passed away, her family was robbed of their goodbyes, and Pete Sam never got to meet his granddaughter, Amah. The mere thought of sending her home with her family was criminal. 2 lives were lost and a family shattered. Certainly the matron was out of her depth, but throughout the months of correspondence with lives on the line, she nor her colleagues took responsibility or action. Ultimately, it proved fatal. Unfortunately, Sam was not the only Native woman to pass away under the auspices of the outing program. In the 1920s, Minnie Doc Myers, a Washoe and Paiute woman, arrived in the Bay Area from Schurz, Nevada. Both Doc and her older sister, Rose Aguilar, outed in the 1920s and became longtime residents of San Francisco. Doc settled in the Hayes Valley neighborhood, and Aguilar was based at her employer's home adjacent to West Portal. Both sisters had their own families. Aguilar had 4 children, and Doc had 3. Typical for Bay Area Indian families at the time, the eldest children, 6 and older, were enrolled at boarding school. Both Doc and Aguilar had children enrolled at Stewart, their alma mater. Both were single mothers working in the city and separated or divorced from their partners. In February 1931, Doc became seriously ill and was hospitalized in San Francisco. Matron Royce petitioned Dr. Snoddy of the Pyramid Lake Hospital to admit both Doc and Ivy Sam. In response, Snoddy sent his regrets. There were no additional beds, and they were already over capacity. Royce became irritated and looked for intervention from Superintendent Parrott of the Walker River Agency. Snoddy's refusal to admit Doc put Royce in an embarrassing position because she had promised the San Francisco County Hospital that they would admit Doc soon. As with Ivy Sam's case, Royce gave Doc's health providers the impression that she would be immediately transferred to a government hospital, but that was not the case. So Royce appealed to Parrott. I'm wondering if you could take her at your sanatorium. The case is tuberculosis of the bone, and the girl wants to be to a place near her home, which is Schurz. Thankfully, Parrott responded quickly and made room for Doc at the Stewart Sanatorium. Royce was grateful for Parrott's assistance after Ivy Sam's death. While she arranged for Doc's transportation, she expressed her gratitude of the superintendent. Thank you so much for accepting Minnie. I have worried greatly over her case. After some back and forth between OIA officials, Doc's transportation to the Stewart Sanatorium was finally arranged. And on Friday, March 13th, she and an attendant boarded the train to Nevada. It appears that both Doc and her sister Rose furnished the transportation funds amounting to $37, or roughly 1 month's outing wages. Rose Aguilar was reimbursed $20.09 for her sister's and the attendant's ticket. Minnie Doc was given $2 and later refunded $2.91 after the cost of her meals and tips. Further, the reimbursement of Minnie Doc's $9 sleeper ticket was still up for consideration at Parrott's discretion. While the outing program transported Native women to the Bay Area for outing work, it did not make itself responsible for their return ticket, even in the event of a medical crisis. Despite being very unwell, Doc withstood the trip to Stewart. Once at Stewart Sanatorium, Doc sent a message of thanks to Royce, who responded on March 18th. I am so glad that you're at last where you so much wanted to be, and I do hope that you will get real well and strong once more. It is so nice that you can see your 2 children often. Indeed, Doc's relocation to Stewart Sanatorium meant that she finally saw her children and her relatives. Doc's return to Nevada must have felt like a relief, but the joy was short-lived. On April 27th, Minnie Doc died at 31 years of age. Minnie Doc's case demonstrates how access to healthcare and healthy living conditions was a privilege that urban Indians could not rely on in the early 20th century. By contrast, with Ivy Sam's case, at least 1 bed was secured for Minnie Doc, and she saw her children and family before she passed away. But these small acts should have been the standard rather than an exception to the rule. Although Doc resided in San Francisco and apparently qualified for long-term hospitalization, Bay Area-based physicians were eager to pass her off to another facility, in this case, an out-of-state institution. In this way, Doc's fate was similar to Ivy Sam's. In the interim, Royce was embarrassed for her inability to deliver on promises she had made. It is difficult to know what more could have been done for Doc, yet it is fair to say that a hospital bed at Stewart Sanatorium did not guarantee the best of care, or perhaps even adequate care. Though many OIA hospitals specialized in treating tuberculosis on account of the rapid transmission of the disease on reservations and in boarding schools, such facilities may have simultaneously spread the disease. Moreover, they were subject to chronic inadequacies in qualified staffing and supplies. In short, these federal facilities may have been deadly. Although perhaps her care was better handled than Ivy Sam's, we still end with the same result: another Native woman and mother gone before her time. A final case also had a more promising start, but a less than ideal ending. In 1929, Blanche Nixon Spott, a Klamath woman, arrived in the Bay Area at 16 years old. Nixon came by way of Ruth Roberts. Robertson's husband was an accountant at a cannery on the Lower Klamath. There, Roberts befriended local Native women and brought them to the Bay Area for work. Roberts' unofficial job resembled that of an outing matron, but she was not a federal employee. Nixon's first official outing position was at a Piedmont home, earning $30 a month. Matron Van Every's notes indicate that Nixon had health issues. She wrote, "Her health will never permit her to live in the Bay region." Nixon suffered health issues that made wage work impossible, and yet she remained in the Bay Area for this very purpose. In the summer of 1935, Nixon was employed at Ball Cannery in East Oakland, but was not strong enough to endure the demanding peach season. Her previously injured knee was especially limiting. One day at work, Nixon fainted. She was rushed to Highland Hospital in Oakland and was diagnosed with active tuberculosis. Nixon's brief Bay Area residency meant she was not eligible for long-term care at Fairmount Hospital in Oakland. Therefore, Roberts asked that Van Every assist. Superintendent Bodges of the Hoopa Valley Indian Agency informed Van Every that Nixon was not a ward. She technically did not have access to Indian services, including Indian hospitals. Nonetheless, Bodges offered Nixon a bed at the Indian Service Hospital at Hoopa. He also recommended Southwest-based sanitaria. Though Bodges cautioned, they are all crowded, and usually there is a waiting list. Tuberculosis was rampant in Indian country, and yet the Indian Service was ill-equipped to manage the disease. Further, though the BCG vaccination was developed in 1921, the Indian Health Service did not administer the inoculation until 1935. Ultimately, Nixon was treated at the Hoopa Hospital, and thankfully she was strong enough to withstand the rail trip home. On January 1st, 1936, Nixon returned to the Bay Area for work. That fall, her health issues returned. In September, Nixon came down with a cold and a low-grade fever. By late October, a physician confirmed that Nixon had advanced active pulmonary tuberculosis. Nixon's x-rays showed active tuberculosis in both lungs, requiring immediate hospitalization. Roberts conveyed that Nixon did not want to go to Fairmount Hospital since there had been so many unfavorable occurrences there with TB patients. Nor did she want to return to the crowded Hoopa Hospital. Instead, Nixon desired to be placed at the Stewart Sanatorium in Nevada. Van Every began to research other institutions, the Washaya Sanatorium in Fresno and the Stewart and Schurz Sanatorium. She petitioned Superintendent Bodges again for guidance. In her petitions, Van Every noted that while Nixon was full-blooded, she was not a ward. She also added compelling language stating, "She is a woman of good character, willing to work, and is the support of her 2 children. She has been employed in Oakland since January of this year until the past 2 months." Van Every's comments on Nixon's character, familial commitments, and willingness to work likely served to influence Nixon's admission, asserting that she was a worthy cause. Nonetheless, the fact remains that while she was indeed willing to work, her health would never permit her to do so. While Van Every researched Indian Service hospitals, it's important to highlight the fact that Bay Area-based facilities were far more advanced. Because diagnostic services such as x-rays and sputum tests were largely unavailable in Indian Service facilities, Nixon tapped into superior medical care while in the Bay Area. Nonetheless, similar to other outing women, she was required to enter a federally run Indian Service sanatoria or hospital for long-term care. In turn, Oakland-based facilities declared that before Nixon could be admitted to a county hospital, they would have to rule out her admission to Hoopa Hospital. As had been the case with Sam and Doc, yet again, a local institution wanted to pass her off to an Indian hospital. Meanwhile, responses from Van Every's petitions arrived. Seward sent its regrets. It was not a tuberculosis sanatorium. Instead, the official there recommended Fort Bidwell. The Washaya Sanatorium also was not an option. Instead, that official recommended Waymar Sanatorium outside Sacramento. Waymar also had an Indian unit. The issue remained that Nixon was a non-ward and Waymar was a paid institution at $2 per month. Finally, Bodges sent Van Every blank applications for admittance to the Southwest-based Indian Service sanitariums, though he cautioned, "These institutions are usually full, and I suggest that you write the strongest possible letter to the superintendent of the sanatorium." Again, Bodges painted a rather bleak picture of the availability of and access to these federal-based sanatoriums. Of the options, Van Every focused on Fort Bidwell. She contracted Roy Nash, superintendent of the Sacramento Indian Agency, about the possibility of placing Nixon there. Nash responded quickly, "As you are no doubt aware, no patients are accepted in the Indian Service sanatoriums unless they are cases that the physician feels will be benefited by sanatorium care. In other words, advanced cases are not accepted," he said. In short, if Nixon was deathly ill, Van Every need not bother. Nothing could be done. Just as Bodges had done, Nash enclosed the application blanks and maintained, if the Indian is a non-ward, it will be necessary for Alameda County or some charitable organization to pay the patient's transportation to the hospital if she's accepted. Nash's unfeeling response revealed that many tubercular cases were in fact too late, and that Nixon's admission was not a guarantee. Further, her non-ward status continued to play a role in her exclusion from healthcare. Nixon was stuck in limbo. Alameda County-based clinicians were adamant about sending her to a federal Indian Service sanatorium, while Indian Service officials insisted on the contrary. While Nixon remained in limbo, a Dr. Thompson gave her a full medical examination. The completed Form 5-363C indicated that both of Nixon's parents had pulmonary tuberculosis, and that aside from her most recent bout, Nixon had been diagnosed with active tuberculosis in 1932. At the time, Nixon experienced a cough, expectoration, chest pain, and a hemorrhage. Rather dishearteningly, Dr. Thompson indicated who to notify in case of death and details as to the disposal of the body. This rare document also commented on the practices of TB treatment within the U.S. Indian Service. A thorough disclaimer detailed, note, advanced cases of pulmonary active tuberculosis should not be sent to non-reservation sanatoria, since the trip is frequently long and arduous. And for the most part, nothing can be done for patients except to make their last days more comfortable. As Nixon remained hospitalized in the Bay Area, Van Every continued to search for a facility that would take her. In mid-November, Phoenix sent its regrets. There were no beds available for Nixon. At this point, Nixon was unwilling to enter Alameda County hospitals, despite the fact that the tubercular clinic there was willing to initiate a hospitalization plan. Van Every conceded the only possible plan was to ask Blanche to go home. Van Every sent Nixon, an active tuberculosis patient, home by train to Crescent City. Thankfully, she was stable enough to make the trip. As Nixon's train departed, Van Every received a telegram. Fort Bidwell had room. Thereafter, Nixon was finally admitted to Fort Bidwell Sanatorium, traveling there directly from Crescent City. It must have been a relief to Van Every, but especially Nixon. After months of back and forth, she finally received the care she needed. A year later, Nixon was still at Fort Bidwell. On September 6, 1937, she wrote Van Every and revealed the inner workings of the sanatorium. Nixon wrote, "Dr. Cartwright was reassigned just last June, and we haven't had any doctor here all summer. However, they are expecting one the later part of this month. Our head nurse is also being transferred to Arizona, so we're hoping a lot of things will be changed." Getting Nixon assigned to Fort Bidwell must have felt like a triumph after several dead ends. Yet a year later, Nixon and her fellow patients lacked a physician on hand, and in short order would not even have a nurse. This casual comment illuminates the circumstances that TB patients in the Indian Service experienced: uneven access to inconsistent care. Nixon added, "I seem unable to improve in health since I've been here. Although I'm up and can wander around, I get a few hours in the morning and the rest of the day is spent in bed. I'm the oldest patient here, as this is more or less a children's hospital. And there are times I get really dreadfully lonesome." Nixon's health seemed to be on an uncertain trajectory, and she was feeling isolated and alone. Several years later, Nixon was still hospitalized for tuberculosis. The year 1940 found her at the Waymar Sanatorium, about 50 miles northeast of Sacramento. Years earlier, the issue of payment for her treatment at Waymar had been an issue, but apparently this was no longer the case. That, or Nixon had some means to furnish the $2 monthly charge. While Nixon was unable to engage in domestic work, Van Every began to sell her crafts in the Bay Area. In particular, she began selling her beaded moccasins. On November 4th, 1940, Van Every wrote, "Several people have admired the little shoes which you gave me when I was visiting you last month. I think of you often, and I'm thankful that I get to see you from year to year." Ever the maternalist, Van Every was generous in expressing her care for Nixon and apparently made annual visits over the years. In the following weeks, the two corresponded about more moccasin orders. Business was booming, and Nixon agreed to make 8 pairs of moccasins at 35 cents each for a total of $6.30. This was a fraction of what she earned while outing, but sufficient to cover 3 months of her care at Waymar. On New Year's Eve, Van Every wrote again, requesting more moccasins for another order. This time she reached Nixon by way of her hometown, Crescent City, California. Perhaps Nixon was home for the holidays. On January 9th, 1941, Nixon wrote from the Hoopa Hospital, where she described a brief visit with her children before setting off for a new sanatorium. She wrote, I was only home for 2 weeks. However, I got to see both of the children before coming here. I am here waiting for my transfer to go through. The doctor seems to think I'll be leaving before long. In early February, Nixon responded with a note of gratitude. Thank you so very much for the money you sent for the moccasins. It is so nice of you, Miss Van Every, to make the sales for me. I certainly do appreciate it. The weather down here is just grand, nice and warm, but I'm sure dreading the summer, judging from what the others tell me. The sanatorium here is just grand, and there are 3 patients that I knew at Bidwell. I'm in the ward with one of the little girls. In a final note, Van Every wrote Nixon, I hope that you are enjoying Arizona and that you will come back to see us soon, looking as brown as your Southern Indian friends. I will miss not getting to see you at Waymar. Van Every's friendly, if clumsy letter was the final document in Nixon's outing file. Ultimately, Nixon's experience appears to have been a success story, the successful placement of an outing woman in proper tubercular care. Unfortunately, the story did not end well. On September 1st, 1943, after 2 years and 7 months at the Phoenix Indian Sanatorium, Nixon passed away. She was just 30 years old. Compared to her peers, Nixon fared well in her ability to enter a tubercular institution, several for that matter. Perhaps the fact that her case occurred years after Sam and Doc meant that she had more access and effective treatments that offered her a fighting chance. It also seems likely that other factors played into her case. Ruth Roberts, for instance, was the route through which Nixon came to the Bay Area, and she may have been a useful advocate. Roberts' involvement in the case may have encouraged Van Every to save face and work diligently towards a solution. Second, the fact that Van Every had a good rapport with Nixon. If Nixon was not in Van Every's good graces, the matron may have felt less compelled to assist. And third, the matron may have known about Sam and Doc's poorly handled cases, motivating her to act quickly. Still, the odds were stacked against Nixon. Both of her parents had pulmonary tuberculosis, and she personally battled it from a very young age. Further, as Van Every noted, Nixon's health would never permit her to live in the Bay Area, much less work. Nixon's case indicates the best case scenario of access to tubercular care, and yet that care remained insufficient. Nixon and her peers found themselves in limbo. Although they had access to emergent services in the Bay Area, they were excluded from long-term treatment. This best case scenario was still a tragedy. The 3 lives I explored today reveal some of the most atrocious aspects of the Bay Area outing program. In Ivy Sam's case, she and her baby were quite literally left for dead. Technically, as a Native woman and Bay Area resident, Sam should have been able to tap into 2 healthcare systems, 1 residence-based healthcare and 2 Indian service-based healthcare. Instead, neither wanted to take responsibility. Sam had complex pre-existing conditions, but her situation was worsened by federal inaction and neglect. For months, she did not receive the care she needed, nor could she see her family. Officials debated her restricted status, while 2 lives were lost. Minnie Doc fared better than Sam, for she was able to secure a bed at Stewart Sanatorium and see her children and her family before she passed away. Like Sam, however, physicians eagerly passed her off to another facility, despite the fact that she was a Bay Area resident and should have had access to Bay Area-based long-term care. Compared with her peers, Nixon's case seems to present a different trajectory. Certainly, Matron Van Every seemed more sympathetic to Nixon's humanity than Matron Weiss had been with Sam and Doc. Ultimately, Nixon received extended care at several tubercular institutions. Nonetheless, she still dealt with the same jurisdictional limbo that Sam and Doc had experienced a year prior. Certainly, Van Every acted quickly and did so more successfully than her predecessor, Royce, but she had to knock on several doors just to secure 1 hospital bed. This process reveals how access to these overcrowded Indian sanatoriums and hospital was a privilege, not a right, even as they offered little more than comfort care. These institutions were chronically understaffed and had little equipment or means to deliver proper patient care. While the rest of the country advanced towards containment and treatment of tuberculosis, the Indian Medical Service appeared frozen. Ultimately, Nixon's experience was the best case scenario of access to tubercular care in the outing program, but her care was still qualified by the limitations of the federal Indian healthcare system and a larger unwillingness at all levels of the government to accept responsibility for Indian lives. As critically ill patients, Sam, Doc, and Nixon all found themselves in a jurisdictional limbo. Officials argued over their status, whether they were unrestricted or a ward, and these debates gridlocked their cases, and their race led to their exclusion from Bay Area-based healthcare. Local hospitals responsible for their emergent care were so desperate to hand them off to Indian Indian facilities, while federal officials hoped that state or county governments would take responsibility for their care. Perhaps these authorities believed the prevailing theories of the time, that Indian people were simply more susceptible to tuberculosis, and therefore not much could be done. Nonetheless, these false notions overlooked the various conditions that created the prevalence of TB in Indian country. In the very broadest sense, settler incursion broke vital community structures that supported traditional health and wellness, largely what we now call mutual aid. Traditional medicines and doctors supported this system. As settlers decimated the land and resources, they dispossessed Native people of the means to care for one another as they had. Federal oversight and management of Native bodies worsened these conditions. The establishment of reservations exacerbated health problems. Compulsory enrollment of Native American children in overcrowded and unsanitary Indian boarding schools put Native children in the crosshairs of death and disease. These institutions were prime conveyors of illness. Children contracted disease at school and spread it into their communities when they returned home. The combination of malnutrition, hard labor, and unhealthy living conditions increased children's risk of developing serious health issues. As boarding school students and graduates entered the Bay Area outing program, they did so with weakened immune systems that would have worsened under the physical demands of domestic labor. And throughout their lives, whether in boarding schools or later in the Bay Area, these Native women had subpar access to even decent healthcare. Early 20th century Indian medical service was underqualified, understaffed, and under-resourced. Preventative care was non-existent, and tubercular care meant comfort care. And while Native women could tap into superior healthcare while in the Bay Area, these same hospitals did not want to treat them. Sam, Doc, and Nixon's experiences are a chilling demonstration of outright federal neglect and state violence in action. Violence that takes root in settler colonialism. Settler colonial circumstances shaped Native health and Native lives, including poverty created by land and resource theft and colonial policies, the establishment of carceral institutions, unequal access to healthcare, and inadequate housing and sanitation, among others. So while officials blamed Native people for the tuberculosis epidemic in Indian country, the true sickness itself is settler colonialism. Thank you.
Thank you, Dr. Keliiaa. That was an amazing and informative presentation. We will now have our brief Q&A session. If you have any questions, please type them into the Q&A box at the bottom of your screen. ARC interns, Kauchani and Alex will be reading our questions aloud for Professor Keliiaa.
Hello, everybody. My name is Kauchani Heredia Brat, and I'm an enrolled member of the Coatzacoalcos tribe from Texas. I use he, him pronouns. I'm a third-year student and an intern for the American Indian Resource Center.
Good afternoon, everyone. My name is Alex Galvin. I use she, her pronouns. I'm a second-year student at UCSC, and I'm also an intern for the AIRC.
Okay, so the first question that we have is, was this program bringing Indian women to cities like this also done in other cities in the United States?
Yeah, that's a great question.
Type it in the chat.
Yeah, the short and sweet answer is yes. Outing programs were a nationwide project. So in that boarding school map that I had, you can imagine that every single school there had its own outing program. Another prolific outing program in Southern California was at the Sherman Institute. There's a really great book on it called Native Students at Work by Kevin Whalen. So if you're interested in learning more about these outing programs, that's another source to look at.
Thank you. Our second question that we have is, would you say that most Native children in boarding schools died because of the lack of healthcare and exposure to diseases?
I think it's a fair assumption to say that. The truth is these schools were very unhealthy. They were not designed really for sort of student success. There are some books out there. For instance, I'm thinking of a book called Empty Beds that really talks about how for a certain period of time, a 20-year period at Sherman Institute, that same school I just mentioned. It was actually a safer school for students to go to. But in the cases of death and disease, yes, it was very common that students passed away from death. And when we talk about, the cemeteries at boarding schools, and when we talk about, for instance, unmarked graves and all of that, I think a lot of this leads to that death and disease. This is not to say that Native students, for instance, did not pass away from other types of issues. But I think it would be safe to say that that was a large issue across boarding schools.
Thank you. The next question is, while it's assumed that the genocide of Native people is a thing of the past, would you consider mass sterilization of Native women by UIHS a modern day form of genocide?
Yeah, absolutely. So this question relates to the fact that in the 60s and 70s, largely there was roughly, people estimate it's about 25% of Native American women at that time were sterilized through the Indian Health Services. So again, sort of IHS as we know it today is quite different, or pretty different than IHS of the 60s and the 70s. But I would say that definitely that literally works into the sort of definition of what genocide is. And more importantly, when we think about forced sterilization or coerced sterilization, I think we're ultimately talking about the same thing that threads through Indian child removal. It's the idea that you're literally trying to prevent futurity, right? So I would say that definitely meets the definition of genocide, absolutely.
Our next question is, how did you get started on your research on the outing program?
Yeah, so I didn't talk about it in my presentation today, but my grandmother was a domestic worker, and I always knew that. I knew that as a fact as a child. And I guess I had just assumed that that was just the kind of work that she could do or, was exposed to. And I didn't realize till much later on that it was the labor that she was designed to do. She was a student at Stewart Indian School in Carson City, Nevada. And she got that kind of education. So she was literally trained to become a housekeeper. At the time, federal officials said, we're doing this so you can learn to become like a housewife. But ultimately what happened is Native women graduating from these schools and moving on from these schools and being in outing programs, they were literally engaging in servitude. So while these schools were supposedly meant to teach and train Native children, Native women, this is the kind of education they received in the early 20th century as they left boarding schools. So I have a very kind of personal connection to this research. And I think that's one of the reasons why I'm so intent on really learning more about it and telling this story that is often not really heard.
Next question is, how do you practice self-care as you research this difficult history?
That is such a good question, because obviously this was a hard talk and it's really upsetting to read these stories. And I think one of the things that I do is I take my time with this research. So for instance, when I first delved into my archive, this is several years ago, this is like 5 years ago. And I remember seeing these cases of Native women dying in the outing program. And I knew I didn't want to touch it. I did not want to touch it at that time. And I was like, I don't know what to do with this. It's very depressing and it's very sad. And largely previous iterations of my work have focused on sort of Native resistance in the outing program, the ways that Native women fought for higher wages or better placements and things like that, basically autonomy. But a year ago, I knew I had these files and I was like, well, we're in a pandemic right now. I feel like I'm surrounded by death and disease right now. Maybe it's a good time to kind of delve into this and look into this story a little further. And as I did that, I think it helped me process the moment that we're in. I think it helped me process the pandemic, and it made me kind of feel connected to a history about 100 years ago that is still very much kind of alive today. But it is difficult work to do. So I think I'll probably put this work away for a little bit before I delve back into these kind of really horrid stories. But I think it's important to tell them, but also, again, take care of yourself. So have someone to talk to as you explore these things. Think about what you need to do. If there might be times when you have to put down this really difficult work and step away. And I think that's what I typically do. Therapy is a great thing too. If you want to talk about ways that you can really process deeply what you're seeing and witnessing in these archives that largely haven't been sort of explored in these stories that are so really difficult to process.
Thank you for your response. Our next question is, do you think the lack of access to adequate healthcare could also explain the high rates of other health issues in Native people, like addiction, mental illness, and diabetes?
Yeah, I think the short answer there is also a yes. I mean, obviously, Indian Health Services is differently nowadays. And I think there, as I mentioned earlier, a positive vaccine rollout, vaccine education, and testing in a lot of communities. But I think that's also because a lot of these centers are now Native led. So that doesn't mean that every center is kind of doing what it needs to do or meeting its community needs. And in reality, this just goes back to the fact that there are environmental factors, there are workplace factors, there are just general livelihood factors that really will put certain communities at risk for certain diseases. So for instance, diabetes. This is an issue that is, experienced in, I think, a lot of communities of color, not just Native communities. And I think this goes, this relates to things like, for instance, the existence of food deserts, right? So maybe this relates to the access of food that you're able to, access. And one of the things that kind of came up as I was delving into this talk a little bit more, as I was researching different urban Indian health centers and different reports that they've come up with. And one of the main solutions that they felt during this time in the pandemic was to basically initiate Indigenous food sovereignty. That not only could we be eating healthier if we went back to sort of Indigenous foods and, didn't eat sugar-based things or highly processed things, but that way we can actually feed ourselves and then therefore avoid going to supermarkets as much or, going into spaces where COVID might be prevalent, for instance. So I think there's real solutions to this, but I will say that yeah, the short end of it is that these problems exist in Native communities because of these societal factors and the ways that, communities have been sort of rendered unhealthy, right?
Okay, the next question is, thank you, Professor Keliiaa, for your presentation and storytelling. I'm curious if you could say anything about what adequate support for Native communities, particularly for those that are opposed to vaccinations, could look like. The concern from many communities, which is valid, seems to be that Western medicine / US health does not have Natives' best interests in mind. Can health institutions gain trust, and what could that look like?
I think that's a really great question. And it's true. I mean, friends of mine, people who are really close to me, Native people, they do not want to get vaccinated. It's not everybody. Sort of broadly, for instance, my entire family is vaccinated. We all got vaccinated at Native American Health Center in Oakland. Again, that same center that was commended by the White House for vaccination rollout and really instilling trust in the community. But not everybody wants to get vaccinated. And I completely understand, as you're saying, it's valid that, Western health and Western medicine isn't always in Native people's best interests. I mean, literally my entire talk was about the failure, right, of these systems. But I do think, and I think one of the things is, I was thinking about IHS broadly, and earlier we mentioned that there was about 25% of Native women who were sterilized by this very same system that, decades later is the thing where most people go to get their vaccination. So I think there is even a distrust in IHS in older generations, for sure, people who experienced, that forced and coerced sterilization. I think what this looks like, where things could look trustworthy, is in situations like Native American Health Center or the Santa Clara Valley Indian Health Center, these kind of Native health centers that are on the ground, where it's literally somebody who's been vaccinated, who believes in the vaccine, who works at the testing site, who wears N95 masks, like things like that. Like, I feel like if you know a person who's on the ground and doing that work and has been safe and has been working to protect their community, I think that's one way that you're able to sort of demonstrate that trust. And again, that's kind of how I came at it too. And I think, Native American Health Center did a really excellent job of, reaching out to Native communities and saying like, hey, we have these particular doses, come by, like we're willing to give this to you. And I think one of the things that was really beautiful is I used to work for the American Indian Child Resource Center in Oakland. So I used to be a tutor for middle school and high school students. So these same students grew up and now they're in their 20s and they are working at Native American Health Center. So the day that I went to get my vaccine, those same kids, those kids that I used to tutor, they were the ones helping me throughout this process of getting vaccinated. They're the ones who are working at the testing sites. So I think kind of that intergenerational sort of circle there really made me feel such strength and power in saying, hey man, my community is looking out for me. My community is taking care of me. So this is not the case for everybody. Some people are still not going to want to get vaccinated. It may take some time, but seeing those pretty high vaccination rates, 50%, I mean, that's also pretty good. So I think that's one way that communities are able to instill trust and really demonstrate that mutual aid that I think Native communities are actually so very good at. And when they do this themselves and when they drive those efforts are acknowledged and recognized and embraced.
Thank you. Okay, our next question is, what is your main motivation to continue your work?
I think what I'm all about is stories and histories and uncovering them and revealing them. I come from a background in Native American studies, and even outing is fairly specialized. So every time I give my presentation, I got to do some back work, to kind of contextualize all of that. And so it just reminds me that this work is very kind of specific and therefore is sometimes something that people really haven't even heard of, even if they're in a specialist of the broader field, right? I think it's also important to know the true and real impact of boarding schools and outing programs. Because, for instance, this summer, unmarked graves were found in Kamloops in Canada. And it really sparked this conversation of what is the real impact of residential schools in Canada, Indian boarding schools in the United States. And I think we need to know that. I think this has kind of been on the tip of people's tongues for generations here in the United States. And I think we're at a very prime moment to begin to interrogate these things. It's going to be very difficult. There are atrocities abound, but I think it's very important because the more that your average American citizen knows about this true history, the more they understand the stakes of modern day issues for Native American people. And that's really my goal. I want to educate. I mean, it's why I became a professor, obviously, but I think it's important that we as the general and broader community know this history. We're here in the United States and most people don't know Native American studies. We're here in California. Most people don't know California Indian history. We need to know these things.
Okay, next question. Thank you for your work. I'm left thinking about the recent discoveries of unmarked graves at boarding schools. Your work illuminates how Native women outside of the schools were dying at high rates due to lack of medical treatment. Do you think that some of these women were eventually buried at the schools or in unmarked graves elsewhere?
Wow, that's such a tough question. I never even thought about that. And now that you say it, I think I feel like I have chills from that question. Now that you say it, I think it's very possible, though I will say when I engaged in this work early on, before I really delved into the files, before I just knew, okay, this person died. A lot of the Native women, in fact, were sent to Fairmont Cemetery in Oakland. So I know for a fact, for instance, that Ivy Sam's body was, in fact, she was buried in Oakland. I don't know when, but sometime later, her family brought her back to Nevada. So at one point they moved her gravesite and she is now in Nevada. And I think that would mean it would take family members sometime, maybe a generation or two later, to get the funds to be able to accomplish that, because it actually is very expensive to do that. One of my things is that I've always wanted to go to visit the women who were buried in Oakland. It's just so raw that I haven't done it yet after all these years. And my hope is that I find that other Native women were in fact, brought back to their families. But it amazes me that there was very little consideration for bringing them back home. It disgusts me. And I'm just reminded that this is what our federal government has done. But your question about whether or not they are part of these unmarked graves, I mean, it's very possible. And I think that relates to the question earlier of how did Native children pass away? I think if Native children pass away from disease, it would be easy to say this person passed away from tuberculosis or whatever disease it may be. If they passed away from being physically beaten or shot or anything like that, that's probably an unmarked grave. So I think unmarked graves actually can reveal the more even atrocious circumstances that should not have been written about, that didn't make it into the files, that things that people tried to really hide and conceal. So again, I know I'm talking about a really difficult topic. So again, take care of yourselves. But yeah, that is a chilling question.
Thank you so much, Professor. We have time for one last question. And it is, has your research shown anything about surgeries related to tuberculosis?
That was surgeries related to tuberculosis?
Mm-hmm.
Not that I have found, because again, at this period of time, in the United States broadly, globally at that time, there wasn't a lot of treatments that could be done aside from kind of like inoculations and things like that. And if there were, the Indian Medical Service wasn't even doing them anyway, because it was sort of comfort care, right? So what we largely see is that, you know, people kind of lie in their bed all day, and that's kind of the care they receive. So it's very similar to what we learned about Blanche Nixon, you know, being at all these different facilities and kind of being in bed most of the day. There were not a lot of advanced sort of medical treatments at that time. And it's kind of really sad because when I think about these cases in the 30s and all of that, a lot of these women, if their cases had happened 5 years later, they might have had some type of treatment. They might have been able to survive. But we're seeing broadly a sort of inability to treat tuberculosis, but more specifically in Indian health services.
Thank you so much, Dr. Keliiaa, for sharing your research with us today. I really enjoyed hearing about your work. And if anyone would like to reach out to Dr. Keliiaa, here is her email information. And we will now conclude this event with final words from our program coordinator, Gemsy Ortiz.
Thank you, Chani. Good afternoon, everyone. My name is Gemsy Ortiz. I use she, her pronouns, and I'm a Northern Cheyenne tribal member. We appreciate you all taking the time to be with us today. I want to extend a special thanks to the entire American Indian Resource Center team. All of our events are student organized, and I'm sure you agree they did an outstanding job today. Our lead interns, Sarah Zamarialai and Tawny Henningsen, point person for this event, Kamiko Hostler, our Q&A moderators, Chani Heredia Bratt and Alex Galvin, and our fellow team members, Andrea Lopez and Jordan Perkins. We would also like to thank our director, Dr. Hernandez, for always guiding and supporting us. We have an amazing team who works very hard, so thank you all. We hope to see you at our future events. This coming Monday, November 8th, we have a book talk with Professor Sim Schneider, who will be in conversation with fellow tribal members, Dr. Peter Nelson and Nick Tipon. It begins at 4 p.m. Pacific time. And Indigithanks is coming up on Friday, November 19th, 2021, with guest speakers Vincent Medina and Luis Trevino, the founders of Cafe Aloni. The links to register for those virtual events have been shared in the chat below. Today's event was recorded and will be uploaded to the American Indian Resource Center YouTube channel. Stay up to date with the ARC by following our social media channels and subscribing to our YouTube channel. Finally, the link to the event evaluation is in the chat as well. We will send an email to everyone who registered with the evaluation form if you cannot complete it right now, but we really appreciate your feedback so we can continue to improve our events. Once again, thank you all. Thank you, Professor. Thank you, Chairman Lopez and Amah Mutsun Tribal Band members who are here with us. See you soon and take care.